Welcome back. For this lecture, we're going to continue on in the Airway series by discussing basic ventilatory management. Emergency medical care begins with ensuring an open airway. As we discussed in assessment, the ABCs of assessment, airway, breathing, and circulation, airway and breathing are two of the first things we're going to assess in a patient. As we arrive to a patient, particularly if the patient is unconscious or appears to not be moving, one of the first things that we're going to do is to open the airway and assess breathing. When we go to open the airway, particularly in an unconscious patient, we want to make sure that we position that patient correctly. For this instance, we're going to talk about placing the patient in the supine position. The supine, or face-up position, allows us the opportunity to manage the airway and get a good visual inspection of the airway and assess breathing and circulation appropriately. When we move patients that are unconscious, we should move them as a whole. In other words, you should make sure that you take care to have one person at the head and at least one person on the body so that you roll them as a unit to make sure to not articulate muscles and joints and cause potential further damage, particularly if you suspect trauma and need to protect the C-spine. The number one airway occlusion, or the thing that occludes the airway most frequently, is the tongue. As you see here in the side view, the tongue can slide back into the back of the oropharynx, occluding the airway, and is the most common airway obstruction. For opening the airway and assessing the airway, we're going to use one of two techniques. We'll either use the head tilt chin lift maneuver or the jaw thrust maneuver. The head tilt chin lift maneuver is for patients who have no suspected trauma or cervical spine injury. This is because it articulates the spine when we open the airway. To perform the head tilt chin lift maneuver, you'll place one hand on the head of the patient, with the other hand, two fingers, under the jaw, and you will tilt the head upward, allowing the tongue to be pulled forward and away from the oropharynx. The other maneuver is the jaw thrust maneuver. For the jaw thrust, we're going to use this in patients that we suspect cervical spine trauma or have some index of suspicion that there may be injuries present that could be exacerbated by articulating the spine. For the jaw thrust maneuver, you're going to follow the steps below. You're going to kneel above the patient's head. You're going to place your palms on the cheekbones of the patient and moving your fingers behind the angles of the lower jaw. Collapsing your fingers into your palms, you're going to move the jaw upward, and you can use your thumbs to help position the jaw. This will cause the mandible to move out and upward, thus lifting the tongue again out of the oropharynx. This process can be painful, so be mindful of that as you're practicing in lab or as you're performing this in the field as well. Occasionally, we may need to open the mouth to be able to inspect the airway. So even if the airway is open, the mouth may be closed and we can't get a good assessment through visualization or may need to insert an airway adjunct. For opening the mouth, we use a scissor technique or a cross finger technique. You're going to place your thumb on the lower teeth, or the teeth of the mandible. You're going to place your middle finger or index finger on the maxillary teeth, and then you're going to scissor your fingers apart. That will open the mouth. Be mindful if you're going to insert something into the patient's mouth, especially your fingers, because during events such as seizures, you can sustain injury. Suctioning may be needed to remove foreign bodies, particularly liquid foreign bodies such as emesis or vomit, or blood or secretions from the airway. In order for a patient to adequately ventilate and subsequently oxygenate, that airway must remain patent. There are several types of suction devices you're likely going to run into in the field. Some will be battery-powered portable suction devices, as you see on the right-hand side of your screen. Some will be wall-mounted suction machines, such as in the ambulance or in the hospital bay. And then you may have manual suction machines, such as the one listed under A there. Suctioning has some key roles that you need to be mindful of. You're going to have multiple options for suctioning tips or attachments that will go onto the end of a suction device. We generally divide these into soft tip suction catheters and rigid suction catheters. You're going to want to make sure to have access to sterile water or sterile saline to be able to rinse the catheter in between uses as well. Make sure for your suction equipment, you're inspecting the equipment regularly. This should be performed at least daily and make sure that your suction, when it's creating a vacuum or the suction is turned on, that it's not creating a vacuum pressure of more than 300 millimeters of mercury. As far as the techniques for suctioning are concerned, there are a couple of numbers you want to keep in mind. Never suction the mouth or nose for more than 15 seconds at one time for adult patients. We're going to use 10 seconds for children and 5 seconds for infants. This is because excessive suctioning, particularly after the material has been removed, can lead to additional hypoxia by not allowing adequate gas exchange to occur. When the patients have secretions or vomitus that cannot be suctioned easily, you can remove the catheter from the patient's mouth, log roll the patient onto the side, and carefully clear the mouth with a gloved finger or using the rigid tip suction device catheter. If a patient produces frothy secretions, you can quickly suction them. You should suction the airway for 15 seconds, less in infants and children. Remember, 5 seconds and 10 seconds there respectively. Then you can ventilate for 2 minutes and then continue that alternating pattern until all the secretions have been cleared. Frothy secretions typically occur with pulmonary edema patients or deeper pulmonary issues that may not be resolved with just brief suctioning. We have additional airway tools that we use to maintain an open airway. As mentioned previously, the most common occlusion for the airway is going to be the tongue. So these next two devices that we'll discuss focus solely on pulling the tongue away from the oropharynx to allow air to pass through and subsequently enter the lungs for gas exchange. Oropharyngeal airways, or OPAs, are rigid devices that go into the mouth and pull the tongue away from the back of the mouth, thus clearing the airway. There are some specific indications and contraindications we need to discuss for these. Firstly, under indications, it should only be used in an unresponsive patient without a gag reflex. This is because it goes into the device, the OPA, enters the mouth, and can stimulate the gag reflex, particularly in a responsive patient, thus leading to emesis and further airway occlusion. We typically only use the OPA for unresponsive patients without a gag reflex, for apneic patients who were assisting ventilations with a bag valve mask. The OPA is contraindicated in any conscious patient or patient with an intact gag reflex. The other type of basic airway adjunct that we use are the nasopharyngeal airways, or the NPAs. These are used in patients who are unresponsive or have an altered level of consciousness, but still have an intact gag reflex and have an inability to maintain their own airway spontaneously. Unlike the OPA, the NPAs are inserted into the nares of the nose and pass through the nasopharynx into the oropharynx to allow passage of air. These patients will use NPAs, it's indicated if they are semi-conscious or unconscious with an intact gag reflex, and otherwise patients who won't tolerate oropharyngeal airways. Some contraindications to be mindful of: severe head injury with blood in the nose, or history of fractured nasal bones can lead to complications with the NPA. We also can use patient positioning to help manage vomitus, emesis, secretions, or blood in the airway that needs to be drained away. We can use the recovery position, and this is placing the patient on their side, bringing one leg forward and their hand under their head to help position their airway, and it allows secretions to drain appropriately when needed. When a patient is not ventilating adequately on their own, so if we have a patient who has hypopnea or low ventilation, or perhaps hyperventilation or hyperpnea, we may need to assist ventilations to ensure adequate tidal and minute volume for oxygen delivery. The tool of choice for EMS and medicine in general is the bag valve mask. You can see the bag valve mask on your screen here to the left. It's comprised of a face mask, a connection section with a PEEP valve, a pop-off valve, and an expiratory valve. It's then connected to a self-inflating bag, an air inlet, and a reservoir bag. It's important to note the picture on the right of your screen where the provider is using something called the EC technique for holding the bag valve mask in place. It's important to maintain a good face-to-mask seal And by performing the EC technique, or having your thumb and your index finger on the mask, and your remaining 3 fingers under the mandible, lifting the jaw forward, you can get a good face to mask seal and deliver adequate ventilations for the patient. Signs and symptoms that we may need to use artificial ventilation are if the patient has altered mental status, accompanied with inadequate minute volume. And remember that minute volume is just tidal volume, or the rough amount of air that someone is moving per breath, times their respiratory rate. Excessive muscle usage or excessive fatigue. Make sure that when you're using a bag valve mask, particularly on a conscious patient, that you explain the procedure to the patient. Place the mask over the nose and mouth. Squeeze the bag each time the patient breathes if you're assisting ventilation. If you're not assisting ventilation or the patient is apneic, you're going to want to squeeze the bag just enough to see the chest rise. Remember that tidal volume is only 500 milliliters for an adult patient. So squeeze the bag just enough to see the chest rise. And you're only going to deliver 10 to 12 breaths per minute. Excessive ventilation can lead to significant complications with the bag valve mask that we'll discuss here shortly. Once the patient is not breathing, begin your artificial ventilation. In the pre-hospital environment, I know that you'll have an American Heart Association BLS for Healthcare Providers course, and they'll discuss the use of mouth-to-mask or mouth-to-mouth technique. To maintain appropriate personal protective equipment, we will use a bag valve mask whenever possible, and we'll use the 1-person or 2-person bag valve mask technique to ventilate those patients. While we discuss some of the complications, let's refresh a little bit about the ventilation process in a normal patient. As a reminder, ventilations occur through something called negative pressure ventilation. In normal breathing, the diaphragm contracts. That increases the volume of space in the thoracic cavity, thus causing a reduction in pressure, and air flows from the outside environment into the lungs. Expiration, or breathing out, is the opposite of that process. When we introduce positive pressure ventilation, we change those dynamics significantly. It's important that when we deliver breaths through positive pressure ventilation, we only ventilate at 10 to 12 breaths per minute and only supply enough air with each breath to see the chest rise and fall. This will help prevent complications such as gastric insufflation, which we'll show an image of here in just a moment, or complications associated with increased intrathoracic pressure. Because you are transitioning to positive pressure ventilation, you are increasing the net pressure effects in the chest cavity. Because the lungs are not the only organs contained within the chest cavity, as a reminder, the mediastinum contains the heart and the great vessels, that pressure is also applied to the cardiovascular system and can reduce cardiac output. So be mindful while you're giving ventilations to monitor blood pressure and cardiac output. With excessive ventilatory rate or ventilatory pressure, air will move out of the lungs or be forced past the epiglottic opening into the esophagus and ultimately down into the stomach. This complication is known as gastric insufflation, and you can see here by the image that you see the distended abdomen or distended stomach from a patient. This gas further increases the intrathoracic pressure by pushing the diaphragm upward from the abdominal cavity, further reducing cardiac output and leading to a significantly increased risk for emesis, further complicating your airway management. For mouth-to-mouth or mouth-to-mask ventilation, if you have to use this in the pre-hospital setting, you must use a barrier device, and you need to be able to provide supplemental oxygen. As mentioned previously, the preferred tool in the pre-hospital environment for artificial or assisted ventilation is the bag valve mask device, and you'll get familiar with this device in lab. You may also see, during transport or working in an ALS service, manually triggered ventilators or automated transport ventilators. These are two examples of these mechanically controlled programmable devices that deliver ventilations within specific parameters set by the paramedic for a patient who has been intubated or maybe on CPAP or BiPAP. Generally, these tools are not utilized by the EMT, but if you're in a service where they are utilized, you and your paramedic partner may go over them so that you can aid and assist in setting these up when they're necessary.